You're listening to Medscape's In Discussion series on breast cancer and HER2, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Kathy Miller, Valve Lentero Professor at the Indiana University School of Medicine, Department of Medicine, Hematology Oncology Division. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hi, I'm Dr. Kathy Miller. Welcome to the Medscape In Discussion podcast series on breast cancer and HER2. Today, we're going to be talking about recent changes in the management of metastatic HER2-positive disease with my guest, Dr. Sara Tolaney. Dr. Tolaney is an associate professor in the Department of Medicine at the Harvard Medical School and chief of the Division of Breast Oncology at the Dana-Farber Cancer Institute in Boston. Dr. Tolaney is also a veteran of the In Discussion podcast because she also joined us on season 1. Dr. Tolaney, welcome back.
Thanks so much, Kathy.
So I want to first ask you to take us on a trip through memory lane and what we considered standard of care in the first-line setting before the Destiny-09 results.
Yeah, so for now, over a decade, really, we've utilized the Cleopatra regimen as our first-line standard of care for patients who have metastatic HER2-positive breast cancer. So we've been giving upfront therapy with a taxane in combination with trastuzumab and pertuzumab. And once we see patients get maximal response or develop toxicities, then we've moved on to use trastuzumab and pertuzumab as maintenance. Over the years, we started integrating the addition of endocrine therapy to that trastuzumab, pertuzumab maintenance for those patients who have ER-positive, HER2-positive cancers. Although that wasn't allowed within the Cleopatra trial, we've seen data emerge over the years, including data from studies like PERTAIN, suggesting that using endocrine therapy with trastuzumab and pertuzumab can be beneficial. We really have been doing that now for, again, over 10 years, and it has really been the gold standard for our patients.
We should mention, though, it's been the standard for 10 years, not for lack of trying. There was the Marianne trial that we hoped would replace the chemotherapy with an antibody-drug conjugate. In this case, the antibody-drug conjugate tested was T-DM1. But I think to the surprise of most of us at the time, the Marianne trial was not positive. The ADC was not better.
Yeah, I will say I also was surprised when that data emerged. I think I was very hopeful that TDM1 would be a step forward. But as you point out, I think we were all disappointed. They even tried adding pertuzumab to TDM1 to enhance that benefit within that trial, and the pertuzumab didn't add to TDM1, so it didn't push us over the edge to get superiority.
So we do now have the results of the Destiny-09 trial, and THP reigns no more. So remind us the design of the Destiny-09 trial and what patients were eligible for that effort.
Yeah, so the Destiny Breast 09 study was a trial for patients who had previously untreated metastatic HER2-positive breast cancer. So you could either have de novo metastatic disease, or you could be a patient who had a recurrence of HER2-positive breast cancer. And patients were randomized to one of 3 arms. They could get TDXD alone, or TDXD plus pertuzumab, or get the standard Cleopatra regimen, the THP therapy. And the study was really designed to compare the efficacy of each of the TDXD arms to the control, the THP. So in essence, looking at TDXD alone and comparing it to THP, and then comparing TDXD and pertuzumab to THP. But it was not designed to compare the 2 TDXD containing arms. I think the other thing that is important to realize is that within those patients getting TDXD, the TDXD was continued until time of disease progression. And so you stopped TDXD if you developed toxicity or you developed progression. If you stopped early due to toxicity, then you could go on to get trastuzumab alone if you're in the TDXD monotherapy arm, or go on to get trastuzumab and pertuzumab if you were in the TDXD plus pertuzumab arm. And the control arm was really designed just like Cleopatra in a sense that you were to get taxane for a minimum of 6 cycles or until development of toxicity, and then go on to the trastuzumab, pertuzumab maintenance. And physicians could elect to add endocrine therapy to any of these arms for those patients who had ER-positive disease. They just had to wait until a minimum of 6 cycles of TDXD had elapsed or until taxane had been discontinued.
So that's one big difference from the Cleopatra trial, where
Exactly.
we've realized that blocking ER remains important, even if the tumor is HER2 positive. What proportion of patients had de novo metastatic disease in this trial?
About half the patients had de novo metastatic disease. I would also note that we did cap the number of de novo patients to that 50% ratio. And so, I would keep that in mind. I do think our space is evolving as time goes, at least in the United States. I think we're seeing that the prevalence of de novo disease is rising.
So I know we're always interested in overall survival. That's going to take much longer follow up. But tell us about response and progression free survival thus far.
The data that we actually had presented at ASCO was actually the interim analysis. So the study was designed to really test for success at an early time point at this interim. And the combination of TDXD and pertuzumab met that very stringent threshold. You had to have a p-value that was less than 0.00043 to meet the criteria for success. And so that combination arm did meet that threshold, but the TDXD monotherapy arm did not meet the threshold for success. So that the data that we have from the interim again is just for the comparison of TDXD pertuzumab to THP. The TDXD monotherapy arm remains blinded, and so that data we'll see at the primary PFS analysis. But what we saw was that the TDXD and pertuzumab did a lot better than the THP. There was a statistically significant improvement in progression-free survival that went from about 26.9 months to 40.7 months. So, in essence, almost doubling progression-free survival when you used TDXD and pertuzumab. The overall survival data, as you alluded to, is highly immature at this point in time. There's certainly a nice trend favoring the TDXD and pertuzumab, but far too early and will need much longer follow-up.
I think often people are skeptical of interim analyses, but having been on several independent data monitoring committees, that has actually taught me to pay more attention to interim analyses because the threshold for success at those earlier looks are so much greater than the threshold for success at the primary final analysis. It has to be a huge benefit. And you just gave us some really big PFS numbers. Most striking, perhaps, is that the PFS with THP was so much better than in the original Cleopatra trial.
Yeah, so that's actually interesting. I thought the same thing when I saw those data for the first time because, as you're alluding to in Cleopatra, the PFS for THP was a little under 19 months. And here we're seeing it's a bit better. And so one could say, well, was it because we did allow endocrine therapy in the THP arm for those ER positive, HER2 positive patients, whereas you pointed out it was not allowed in Cleopatra? I would say that could be contributing, but I would note that only about 40% of the ER positive, HER2 positive patients actually got endocrine therapy. So not every physician chose to add the endocrine treatment. This trial, we hadn't seen the data, and I'm sure we'll talk about this from Patina when this study was initially enrolling. And so maybe that will change over time with utilization increasing. But one thing that's really interesting is you dig into this data, the data that was the primary endpoint analysis was progression-free survival by blinded independent central review. But in fact, when you look at the progression-free survival using investigator assessment, the PFS for the control arm is more in line with Cleopatra. So it's around, a little over 20 months. And so there was some discordance between the investigator assessed PFS for the control compared to the blinded independent central review. So I do think it's interesting. I think it performed more in line with what I was expecting with the investigator assessed.
The fact that only 40% of the ER positive patients got endocrine therapy, it just makes me sad because it is highly likely to have extended their period for progression, which in many cases means delaying the period of time that they move on to other therapies with perhaps greater toxicity. So we're going to keep talking about that to make sure those patients get the opportunity to benefit from hormone therapy.
I totally agree with you. I think I was disappointed to see that number because I think our standard has evolved over the last several years where we really are uniformly using endocrine therapy in that maintenance phase. And, that needs to be encouraged because it really does extend the duration of disease control and symptom control for our patients. So, it's a very important component that was not utilized by the majority of patients.
So I want to ask you about perhaps a different strategy because with chemotherapy, naked chemotherapy, we'll call it, it's common to give patients an induction treatment of variable duration depending on response and toxicity, and then pause the chemotherapy, continue the antibody therapies alone to maintain that response and reduce toxicity. We haven't thought about the antibody drug conjugates in the same way. We've thought about them as you continue for as long as possible and only if toxicity really pushes you. I'm wondering if that does our patients a disservice. They are chemotherapy. The toxicities are different for many patients, but not all. They're less. But I have a decent number of patients in my practice now who've responded really well over time have just gotten more weary, shall we say, of the ongoing toxicities. And we've reverted back to the antibody therapy to find that better balance. Do you think that is something we'll be able to study in this population in the future?
You bring up an incredibly important point. These patients with HER2 positive disease are often on their first line of therapy for years, right? And so to imagine to be
We're looking at 40 months here.
and to be honest, that may not be the accurate median because this is an interim, right? And so you can imagine that that median is likely to be longer because over 40% of people were still on TDXC and pertuzumab at the time of this interim analysis. So you're right. This median can be a long time. And so the thought of being on chemotherapy for that long, I think is daunting, particularly to our patients. And so I will just say, maybe in defense of the design, is that when we designed this trial, we had actually only seen the data come out from Destiny Breast 01. So it was designed at the very end of 2019 when that data emerged. And so we didn't really know that this drug would have such dramatic benefits like we saw in Destiny Breast 03. We didn't know there was a survival benefit from the agent. And so we were kind of taking a leap of faith when designing the DB09 trial. And in fact, that's why there is a second arm of TDXC and pertuzumab, because one could have thought if you knew the data from Destiny Breast 03, why would you have tried an add-on strategy? Because you already knew it was a home run, even in a pretreated population, but we didn't know that. And so we were trying to think about ways to enhance outcomes compared to Cleopatra. So, we were looking at strategies that were even add-ons. So we were nowhere near the point of thinking we could get away with an induction maintenance strategy because, again, we just didn't have enough data at that time. But now seeing that you could achieve over 40 months of PFS with continued drug administration until progression-free survival, I think does lead to this question, could you achieve similar results with an induction maintenance strategy, kind of a la Cleopatra-esque of a design? And so as there is actually a single arm phase 2 ongoing called the Demether trial, which is kind of taking this concept and putting it into action. So the study gives 6 cycles of upfront TDXD and then switches patients over to trastuzumab and pertuzumab after the 6 cycles. And physicians can add endocrine therapy for the ER-positive, HER2-positive subset. So that will give us at least some initial data for how an induction maintenance type of strategy would work. Obviously, there are limitations to single arm analysis, but I think it'll be a good test to see how this kind of strategy could work because I think it is a direction we'd like to see us move towards. But I would argue one thing that I would like to better understand is what is the right duration of TDXD? Because I don't think we need to be giving it continuously till progression, but I don't know that we can also cut it off at 6 cycles. And so, it's not a drug that's limited by neurotoxicity like taxane is. You could give it for a bit longer, try to get someone to true maximal response, and then maybe switch to maintenance. And so there are a lot of studies that are being designed and planned to think about how to do this correctly. So I think we'll see more in the future on this subject.
I'm delighted that's being evaluated because I think that's really important for our patients. I think ultimately the appropriate randomized comparison would have to allow those patients who had entered maintenance to resume the ADC and only consider the PFS after progression after resumption, because I do worry that a slightly shorter PFS with that maintenance strategy could lead to people abandoning it rather than thinking if I got some induction period of time and then a period of months to a couple of years on antibody therapy, now my disease is progressing and I resumed and got a second induction with the same ADC and again got disease under control. If that total was the same as continuing the ADC the entire time, I think for many patients that would still be a win. So the thinking about endpoints and the designs of those trials, I think is going to have to be very careful so that we're really asking the question that's relevant to our patients.
I think you're very insightful because Demeter, in fact, does allow re-exposure to TDXD, but they did not take your advice in the sense that they did look at their PFS analysis cuts off at the time of progression after TDXD induction maintenance. It doesn't count the re-exposure to that total PFS sum because I do see your point that,
I'd want to know both.
yeah,
And if
exactly.
patients are only offered for a couple of months, then we might not have gained much.
Yeah.
But having done this outside of a clinical trial in many of my patients, some of them are now a couple of years on antibody alone therapy without progression. So I'm sure there'll be variability. I'd be interested in knowing the medians for both, quite honestly.
Yeah, no, I think you're right. This will be really important information for us to know.
So this has been a fascinating lead in to the other questions that come up in this situation, which is, do you think we're going to care about the Destiny 09 results a year or two from now, other than perhaps in the de novo metastatic disease? We're not going to go into the details of the neoadjuvant results or the post-neoadjuvant results in this episode, but we've now seen early clinical trial results that using TDXD in the neoadjuvant setting improves pathologic complete response rate. We'll need to wait longer for the event-free survival, and that TDXD was superior to TDM1 in the post-neoadjuvant residual disease setting. So you could imagine that a year or two or three from now, our metastatic patients may have already been exposed to this agent in that early setting. What do we do with those patients?
That's a really interesting question. One, I will say I think we are going to have cured the vast majority of our early stage patients. So I think this will be a problem that we will face for a small proportion of patients, thankfully.
There will be fewer of them. And I don't think any of us would suggest that we should hold this powerful agent in reserve for patients who recur. So I'm delighted there'll be fewer of them, but they will be there and they will need treatment.
And I think it'll be really interesting to understand what the biology of these cancers are, because this will be a new challenge for us to understand why someone has resistance to TDXD that's allowed them to recur. And so I think we'll have to learn more. But I will say that the way we often practice, is maybe a little bit more practical than biological sometimes at the beginning when these things change, is that, we kind of use the rule of thumb. Well, if you recurred more than a year out from that drug that you got in the early stage setting, we probably consider re-exposing you. Whereas if you had very short disease-free interval, then we think maybe you're resistant and we won't give you that drug. And so I'm sure that will be done at the beginning. But the truth is, I think we're going to have to understand this resistance. There's some concern that these tumors that are, refractory to TDXD may have lower HER2 expression at the time of progression or recurrence, that biologically, my guess is some of these cancers may be more luminal rather than HER2 enriched. And so I do think there's going to be biological differences. And so I think that'll be important to understand to help us figure out the optimal treatment approach. And so you're right. I do think that we may not be using TDXD upfront if someone has early relapse after a DB05-like regimen, for example. And we're going to have to use other therapeutic options, and we're going to have to figure out what the right ones are.
Well, and I think our best opportunity to begin to understand resistance will actually be from the neoadjuvant trial, because all of those patients had surgery. While a greater proportion of them had a pathologic complete response, they didn't all have a pathologic complete response. So the ability to study those surgical samples of residual disease is really going to be our best opportunity to begin to understand resistance to this antibody drug conjugate.
Yeah, I think you're Exactly right. That's like a gold mine. Um, and I will say that, that arm where they got TDXD alone in Destiny Breast 11, where we saw that the PCR rate was in fact inferior to ACTHP, that tissue I think is going to be particularly intriguing because that really is a pure understanding of why tumors had residual disease after TDXD monotherapy. And I think that will really be important for us to understand.
And that may help us in the metastatic setting as well, where the ability to get biopsies after progression and really dig into mechanisms of resistance is going to be particularly important. So, we're going to have lots more changes and lots of things to discuss over the coming years.
Yeah, I think it'll be really critical. I think right now we're still struggling what the optimal sequences are in the metastatic setting post TDXD. And so I think you're right. This will be very informative for us.
Thank you for joining us. Today, I've been talking with Dr. Sara Tolaney about the changes in the management of first line metastatic HER2-positive disease. The Destiny 09 results, even though they're early, are quite compelling with a at least 40-month progression-free survival. Think about that again a minute. 40-month progression-free survival with TDXD plus pertuzumab in the frontline setting. In that trial, about half of those patients had de novo metastatic disease, about half had had earlier treatment. And perhaps we can do even better because only 40% of the Destiny 09 patients that were ER positive got hormone therapy as a component of their treatment after the initial chemotherapy and initial treatment. So, to our listeners, thank you for joining in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on breast cancer and HER2. Dr. Tolaney, thank you for joining us.
Thank you so much for having me.
This is Dr. Kathy Miller for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Breast Cancer and HER2 podcast series with our host, Dr. Kathy Miller. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on breast cancer and HER2.